Bienvenue à tous, welcome. As they say, trust, let go, and be open. So that's why we're doing here, as this session is delayed. My name is Yvan Bossan. I'm a palliative care physician trained in France. I'm now piloting a research program at Dana-Farber Cancer Institute, looking at the role of psychedelic-assisted therapies in patients with serious illness. It's my great pleasure and privilege to introduce this session. I'm going to try to keep it very brief because it's a hot topic. Thank you all for being here. Thanks you for the organizer of this conference to bring us together and how meaningful that is. I will kindly ask our presenters today to introduce themselves. They will do that much better than me. And we are going to hear 5 presentations today. It will be a bit frustrating because each presenters have only 13 minutes to present. But we are going to hear very important and exciting work that is moving the needle in increasing knowledge and access to psychedelic-assisted therapies in patients with serious illness. We have different perspectives, and so we're very fortunate to have these presenters, and please help me welcome them today. I will say that one thing we would like for all of us to keep in mind as we hear these presentations is how do we recognize, value, honor the knowledge that indigenous traditions have developed through generations, through centuries and millenniums around this work. And we owe them certainly a lot. And they have been able to carry this work through centuries, despite many repeated persecutions, sometimes for the very sake of using these medicines. So thank you to these people. And also in terms of access, how do we think about access as these medicines are developing, not only for the wealthy in our societies who can afford expensive treatments, but also for members of communities who also have suffered from discriminations and racism, and especially through their use of psychoactive substances like psychedelic medicines. So as we are moving this research field forward, can we offer a better setting, for this work for all of our multicultural society? So in that regard, we have the great honor and privilege to have Monica Williams joining us as a discussant today. So Monica, if you mind standing up. So Monica will be joining us after the presentations, and we'll hear her perspective for about 10 minutes. Thank you, Monica, to share with us her insights, hearing about these presentations, and how we can keep these topics in mind. Dr. Williams is the Canada Research Chair for Mental Health Disparities at the University of Ottawa in the School of Psychology. Her work focuses on ethnic minorities' mental health and psychopathology research. She completed her undergraduate studies at MIT and UCLA and received her doctoral degree from the University of Virginia. She completed her psychosocial internship at Montreal General Hospital. She was an assistant professor at the University of Pennsylvania for 4 years, followed by 5 years at the University of Louisville, where she served as director for the Center of Mental Health Disparities. She co-founded the International OCD Foundation's Diversity Advisory Board and serves as the editorial board of several academic journals. She has published over 100 scientific articles, primarily on OCD, trauma, and cultural issues, including in the field of psychedelic-assisted therapies. So please help me welcome Dr. Williams. Thank you. And I will call first our colleagues from Australia. Mark. Thank you very much.
Thank you. It's a great privilege to be here today, to be the first leading today. And it was due to be my colleague Mark Ross, but unfortunately she couldn't make it here in person, so I'm speaking on her behalf. Great slides. Okay. I'll just go back one. Okay, thanks. It's great to have the opportunity. It's hard to know how much people know about the sort of protocols and what's come before and what's going ahead. So I will be brief in my discussion, though, just to make sure that people have a context. We would like to, today our learning objective here is to talk about the fact that we've been able to modify the protocols. Many of the protocols that have been building the evidence base have been focused on those who have got cancer and those who are facing the changing circumstances that cancer brings to their lives, to their psychological as well as their physical makeup. For us, though, we are focusing very much on the end of life, and we're focusing on the last 6 months, well, prior to the last 6 months, where dying is become a more probable circumstance, not necessarily inevitable. Also, we've decided to incorporate non-malignant, so people who sit outside the cancer realm, who really we see in our integrated care clinics for a lot of our chronic illness diseases, cardiac, respiratory, and so forth, kidney. We see the problems exist just as much in that population as the population of those with cancer. Okay. So what I hope to do today, just very briefly, is to really just talk about some of that extension to the work that we're doing, and then just to give you a couple of examples of the cases where we have had to modify the protocol. It's quite unique in Australia. This is our 3 key principles. Mark Ross, who's a psychologist, Justin Dwyer, who's Director of Psycho-Oncology, Psychosocial Cancer Care at St Vincent's Hospital, Melbourne, and myself as Director of Palliative Medicine at St Vincent's Hospital, Melbourne. But as you can see to the left, a number of colleagues who are the actual facilitators and the people that sit with patients who are taking psilocybin as part of the study. So we've really built our study on the shoulders of the people who've come before us, and some of those people are no doubtedly in the audience today or speaking today, where we do utilise both psychotherapy and psilocybin in the 25 milligram capsule, initially randomised between niacin and psilocybin, but then we have a second dosing open label where everyone gets psilocybin 7 weeks after the initial dosing. And it's through this that we've been able to not only think about those that are really looking at the probability of dying rather than the sort of vague possibility, but we've also been able to extend it to, as I said, the non-malignant population of people who can apply to come to reach us. What's been exciting for us is that we've needed, obviously with the pandemic, our opportunity to complete the study by this time this year was delayed, but interestingly, since we've been open to clinical trials again over the last sort of 18 months, we've really kicked a huge amount of goals, and in fact we're hoping to hit our 40 patient mark by the early stages of 2023, which is the aim that we were hoping to achieve in the first place. What's exciting about this for us is we are the first Australian study. It's taken 6 goes for other people to try and get the study up and running in Australia, and it was interesting to see why it was our hospital, St Vincent's Hospital Melbourne, was the one that actually achieved this. The biggest reasons, I think, really came to a couple of things. One is that we're all very clinically focused. We actually saw the real issues and problems that patients, as well as their carers, are suffering as they move through the journey of the understanding of what having a particular chronic or malignant illness is, and the issues that come to play when recognising that death is certainly much more proximal to their being. We're also very sort of part of a similar academic unit where we share and spend a lot of time discussing these things. We've been keeping an eye on the scene, particularly in the US and so forth, and as these people before, to see that we can really step into this space in a meaningful way. The other thing, I think, we had a very supportive research ethics committee, and in fact we went to them with the possibility of starting this study and asked them, what do you want from us to see that we can get this over the line, where 5 other attempts in Australia hadn't occurred. So we sort of opened the door to this occurring. So I think if I were just to talk about these 2 quick cases where we were challenged. So we utilised the protocols that had been used in the US. We utilised the usual exclusion-inclusion criteria and so forth, except we obviously modified them for our study. But we even found at the beginning of the process that we had challenges with the particular protocol. Because we'd spent so much time with our research ethics committee and sort of discussing this, and it took about a good sort of 12 months to move from study design protocol and then getting it through the ethics committee. We all sort of knew each other really well. There'd been a lot of international interest from colleagues in the field, but also from media, particularly the BBC and New York Times. We kept thinking, why is this interest there? But it was quite kind of interesting to see. So we were challenged from get-go, and one of these areas, for those of you that work in the cancer setting, obviously, is the exclusion issue to do with Taxol or paclitaxel chemotherapies. And so we've struck a number of patients who are really facing their dying related to their progressive stage 4 breast cancer. But indeed, we were finding that the use of prophylactic, not prophylactic, ongoing use of Taxol meant that they were excluded. And we actually then were approached by a patient's oncologist to talk this through, and we spent some time working it through to recognise there was this sort of window period in the dosing of Taxol and the dosing of psilocybin where we could actually stop one and allow washout of the Taxol and allow for the psilocybin to then be utilised and then washed out before the next dosing of the Taxol. And it was really this patient who challenged us, but also had a collaborative oncologist who wanted to try and help us find a way through for the study protocol. The other one was a gentleman who, again, because we've opened it up to chronic illness, a guy who's had dying and death dangling in front of him since he most probably had awareness that he had cystic fibrosis. He'd moved from not only having problems of having lung problems, but all the other issues you have systemically from cystic fibrosis, including renal impairment, renal failure. He'd had a failed kidney transplant, but he was also now on dialysis, and this is a relatively young 40-year-old sort of gentleman. He was actually 40, and receiving hemodialysis. So really the utilisation of renal function, which we'd included in the original protocol, really excluded him from being involved in the use of psilocybin in this particular study protocol. So we were able to then go to our research ethics committee to really have a look at this and see that maybe the measures that we're using weren't necessary. The look at the creatinine clearance formula wasn't particularly useful for us in this setting, and indeed we were able to look at the modification of that, and particularly for this gentleman where we had to move him from interstate to come to see us. We had to make sure that he had dialysis the day before the protocol and then and have dialysis the day after the use of the psilocybin organised for as part of his treatment protocol. So I think it's been exciting to see this happen. We were able to go to our research ethics board and we were able to present both of these cases. And so it may not seem like significant modifications, but for us, not only stepping into the non-malignant space, focusing on the 6 to 12 months of life left in prognosis, but also looking at these changes has opened it up to others to come along from our sort of chronic illness environment, but also the social media gets news around to the women's breast cancer groups, And certainly we seem to have had a flurry of activity as people have come to recognise that maybe the rigidity of the protocol can be worked through. I might just leave it there. Just to say that we've managed to enrol both of these people on the program and take it from there. Thank you. I'll look forward to talking afterwards.
Thank you so much, Dr. Boughey. And I think your study is the first one actually conducted within a palliative care, by a palliative care team using psilocybin. So thank you for your work again. I'm sure all of us have many questions. We'll keep them for the end of the presentation after all our presenters had presented. Since we started late, we will also be able, for those of you who can, to stay after the normal end and to extend on the break that's after that. I don't think there is any other sessions after, so we'll be able to stay and continue the Q&As after. Dr. Zarrabi, next.
Thank you. Let me just see if I know how to operate this. The big red button. Uh-oh, did I turn it off with the big red button? Green button. And then we'll get there, we'll get there. And you pressed which button to move forward? Oh, you're putting the slides up. Oh. Perfect. Well, I'll just say hello then. Hi, my name's Ali John Zarrabi. I go by Ali John. I'm a palliative care doctor at Emory University in Atlanta, Georgia. I'm primarily an outpatient doctor, and I also do inpatient hospice and inpatient palliative care. And I'll stop there and then wait till the slides come up. It's my second day in Montreal. It's really beautiful here. If anyone has restaurant recommendations or anything else, you can call them out now while we wait. People really like this tie. Van Gogh's Lilies. It's on Amazon. It's like $12 if you want to buy it. I love vegan food. Do they have good vegan desserts? Yum. Okay. Perfect. Wow. Okay. 2 endorsements. I can just start talking. Oh, yeah. I realized I didn't use the correct template, but that's okay. So we're going to talk about this trial that we're doing at my institution, really elevating the role of the entire multidisciplinary palliative care team, including spiritual health. I have nothing to disclose. The study that we're doing was funded internally and also through the NCI. So what I'm going to describe is a early phase 1 study looking at psilocybin combined with the entire multidisciplinary palliative care team support among demoralized cancer survivors with chronic pain. And that's some information about the study right there. It took 2 freaking years for this to get off the ground. I aged by a decade, and we're enrolling our first 2 patients next week, finally. So it can be done. 3 main objectives. I want to describe the rationale for why we're choosing the population we're choosing. Most of this talk will actually be about outpatient palliative care and less about mushrooms. Identify strengths of chaplains as key facilitators in this model, and for all of us to really voice support for spiritual, geographic, economic, ethnic, and racial diversity in these trials because there's very little. So rationale first. So I'm an outpatient palliative care doctor, and as many of you know, in the States, ASCO has recommended now for 6-7 years that patients with advanced diseases see us early in the trajectory. And what has that looked like in my life for the past 5 years doing outpatient palliative care? my colleagues, my friends all across the United States, I imagine some in Canada, are managing long-term psychosocial issues, including things like personality disorders, anxiety, depression, the confluence and interaction of those things across the illness trajectory, oftentimes for years. I'm assuming a lot of risk with prescribing medications for often years. With benzos, opioids, other medicines, many of my patients have substance use disorders, non-medical opioid use, and negative sequelae from using these medications for a long time. My patients have a lot of these total pain needs. My research is in total pain outside of this work, and total pain doesn't really have much of a scientific basis. It's more of our conceptual religion in this field. And I say that because it's really hard for us to focus right now on which population really needs this medicine most of all, because we don't have the science yet to back it up. Something I'm also seeing is metavivorship. A lot of my patients seem immortal right now with these new trials and these new drugs. And we're part of the REACH study conducted primarily through MGH. And 10 years ago with the initial TEML trial, many of those non-small cell lung cancer patients died. And now over a decade later, they're living. Many of them are living for long periods of time with their illness. So I feel like my work is really rooted in survivorship, and perhaps less so in the end of life when I'm not doing inpatient hospice work. I want to give you a snapshot of the patients that we're seeing in our practice. This is 9 months of patients. We saw about 1,700 unique patients over 9 months in our practice, which is like 4,000 visits. The group in yellow has advanced cancer. Actually, cancer patients make up about half of our patient population. So this is half of our patients. Most have active cancer, and many of them have no evidence of disease and continue to have this quote-unquote terminal diagnosis, and a smaller proportion have potential cure or remission and remain in our practice. And do we think that they need to stay? In our practice, we actually think they do. So all of our clinicians weighed in on how often we should be seeing these patients, and it's kind of the same. 95% of them are on chronic opioid therapy and have significant psychosocial burden. And when you provide upstream palliative care, which is what we are supposed to do, what CAPC, WHO, what we're told to do time and time again, our patients don't die very often. So this is 9 months of our patients, and you can see the vast majority of them are alive and will likely stay alive for quite a long time. So why do I share this? Again, my patients are really, and our patients, obviously, are complex, with complex needs. And clinically, my clinical gestalt is that most of them have demoralization and pain, just by virtue that so many of them are on chronic opioids. And I just want to draw our attention to this New England Journal piece from 10 years ago that delineates what a specialist palliative care doctor is supposed to know and is supposed to do. And it's boxed in red. We are the experts in refractory pain. Refractory to what? I don't know. And the management of more complex depression, anxiety, grief, and existential distress. I'm not a treatment-resistant depression psychiatrist, and yet I ostensibly have the expertise to really manage all of this, according to the New England Journal of Medicine. And I don't mean this in a cynical way, although there's a tinge of it. I really mean this as an opportunity, because for us to really think about finding or providing really patient-centered psychedelic psychotherapy, we as a community have to actually do the work to describe the patients we're seeing in outpatient. And for those of you who are nodding and want to collaborate with me on this, my email's at the end of this presentation. So let's move on to why I'm choosing demoralization and chronic pain. This is not really based on science. This is based on clinical gestalt. If you were at the MAID presentation earlier this morning, there are 56 ways to describe existential distress. Many of us are landing on this syndrome of demoralization because it's very quantifiable. There's an assessment, it's validated. So we are looking for patients with a sense of hopelessness, helplessness, and it's transdiagnostic. You see it in patients with medical illnesses and psychiatric illnesses, and there's so much literature to support it. It's this feeling of being stuck, which is what so many of my long-term survivors feel, the chemo worked, the transplant worked, but now I'm impotent, I can't go back to work, I'm not a breadwinner, I'm not who I was, who am I? And I see that among patients with 6 months to live and my patients with 10 years to live. Also, chronic pain. I showed you that survivorship slide, and I want to really focus that it's not just people at the end of life with pain. 40% of cancer patients have pain after curative treatment and 55% during treatment. Also, cancer pain is very interesting to me because in the mid-20th century, this was the primary outcome for many of those trials. So, we've all heard of palliative care as being that additional layer of care. For me, when thinking about how to design the study, I really wanted to think, how can we get my patient population, 50% African American or Black identified, in an urban setting in Metro Atlanta, to actually experience this kind of therapy within the context of coming in to see us in clinic. So that's what the idea of this trial is. These are the layers of care. Obviously, the medicine is layer one, followed by this beautiful setting. We converted a hospital room into a living room, similar to many of the other studies. And the last two layers are really what we're going to focus on for the rest of this talk. Our patients are going to have access to palliative care, APPs, MDs, social workers, and the chaplain. And it's the chaplain who's embedded in the room during the dosing and is going to be doing 12 hours of preparatory psychotherapy and integration as well. And that's what the innovation of this trial is. It's part of the greater psychedelic chaplaincy movement, which is actually growing in popularity. And I'm really thrilled that at least we say we do, we have the largest spiritual health department in the world. And the chaplains are just hungry to be part of this trial. And why the chaplain? In looking across studies, Dr. Bossan's systematic review, from the 60s on, at least 1 in 4 patients have a profound, sacred, religious, transformative experience. And chaplains historically have been there for that. Our institution a couple years ago had a Templeton where we actually looked at what chaplains do in our hospitals. And the people in Boulder actually on our psychedelic team. What they found was that 92% of the encounters involved active listening, prayers. Religious practices and ministry was actually a teeny, tiny part of what chaplains actually do. I'm sure many of you know that. And most of what the chaplains were doing was engaging in topics related to existential matters like demoralization. So they concluded, our team concluded, that the chaplain has perhaps the best vantage point to support people through a crisis. So again, we're embedding the chaplain along with a trained psychotherapist, and then we're basically passing the baton every couple hours actually during preparation and integration between the MD, the social worker, so we identify whatever we can help with. During the screening process for one of our patients who's signing next week, she's already seeing an acupuncturist. It's not part of the trial, but this is just part of the real life kind of experience we're trying to provide for these patients. And it presents a potentially feasible system in which this can be implemented into clinical practice. Very briefly, we're giving 25 milligrams of psilocybin. This is a safety pilot, and we're just doing this for 10 people to start. We're hoping to be able to do this for more. And we're looking at a ton of exploratory objectives. And this is not the patient-centered part of the study. This is not unlike many of the other studies. That being said, if I actually knew what constructs to target, this would have been shorter. But the reality is, the cat's out of the bag. Oregon's changing, Canada's changing, the world is changing. If I were to do all this preparatory NIH stage 0 work, I would be 50, or I wouldn't say an age. It would be many years from now by the time I could start this trial. So we have a hammer, and it can hit a lot of nails. So I'm looking at a lot of nails. We're also looking at caregiver outcomes. We're collecting blood. It's a 98-day trial. So again, phase 1, recruitment and tapering. We're tapering our first patient off of Cymbalta right now so he can participate. Phase 2 is preparation and integration involving the entire palliative care team. And then phase 3 is assessments following. This is my last slide. I want to say that this is not just lip service, and this is a challenge we're having at our institution. Atlanta's a pretty damn diverse place. Our clinic, again, is half Black, And I've presented at so many tumor boards and meetings, and when clinicians refer patients to us, I will get a phone call saying, this patient's perfect for your study. And then I learned that every single one so far has been white, middle class, or upper middle class, and has a meditation practice, which is great, right? And like, I created a community advisory board, and I felt like I wouldn't need them for the pilot, and I could grow it during the pilot, but it seems like already we're failing. So I want to voice that just because I need to voice it, and that if anyone has any advice about how to do this better, I'm willing to hear it. And that's it. Thanks.
Thank you so much, Dr. Zarrabi. And thank you for keeping the time to both of you. You've been doing a great job. So let's continue on that and have Houman Farzin next. Sorry, Dr. Dingle Spence and Dr. Chris Adrian.
Hi everybody, my name is Chris Adrian, and this is Dingle Spence. The title of our talk is Relief for Grief, a report from 2 psychedelic mushroom treats for bereaved parents in Jamaica. Dingle and I, neither of us have any significant disclosures. Our learning objectives, we're hoping by the end of our very brief talk that you all will be able to describe the landscape of psychedelic work in Jamaica with an eye to be able to identify aspects of a safe and effective retreat, really thinking, maybe clients, patients, people may be coming to you as palliative professionals interested in this work, if they can't do it in the US, asking for advice about what makes a good retreat. And then finally, we hope you'll be able to discuss equity access and psychedelic infrastructure in relation to psychedelic retreats in Jamaica. These are our CanMed's competency frameworks, which I'm dreadfully proud of, but I'm not going to linger on.
Okay, good evening, afternoon. Thanks, everybody. So I just want to do a quick run through and tell you about Jamaica. You can see us there in the Caribbean. We're a very mountainous country. I know everybody thinks we're a beach, but actually there's a lot more mountains than beaches. 2.8 million people. We're mostly black. Much of us are mixed race. And the capital is Kingston, which is in, I don't have a laser pointer, but anyway, it's in the southeast of the country. So I just want to tell you a bit about the regulatory framework that we deal with. We're governed by the Dangerous Drug Act, thanks to being a colony, of 1948, and that obviously allows for the licit and licit movement of drugs in and out of the country. Interestingly, the Act was amended in 2013 to decriminalize and actually legalize cannabis for medicinal and sacramental purposes, which has been great in the palliative care space. Psilocybin, however, which is not known as an indigenous medicine in the country, but does grow wild, and for some reason was never scheduled. And so we are in a very fortunate position that there's no regulations whatsoever governing cultivation, processing, distribution, or consumption of magic mushrooms. Kind of good. That means we can do a lot of work without too much worry. So one of the things that has happened, though, is that people have recognized this, and there are now vast numbers of retreats. This is probably a quarter of the amount of retreats that are running. We are Jamaica Grief Retreats, as you can see there. And I'll talk to you maybe more at the end when we have question time about the last one, which is Jack Creek experiential retreats we want to be able to offer to healthcare professionals. So I want to tell you about this journey that Chris and I and a group of 4 or 5 lovely other people have been on. So we designed, it was a joint vision between Canadians, Americans and Jamaicans to build a psychedelic assisted retreat for parents who've been bereaved. We wanted not just to, because in the beginning we're bringing people in from overseas, but we also want to build an infrastructure that works for our own people and to start having actually Jamaicans attending as well. We're very fortunate to have private donors, and we had a very broad multidisciplinary team, and you can see all the skill sets labeled, written there. And so what we were doing is we were providing 2 legal, safe mushroom experiences within the week that the parents joined us. And that we'll talk a little bit about how, the entry and then what happened in Jamaica and then what happens afterwards. And then it wasn't just all about mushrooms. Of course, it's a beautiful country, people, and part of the work is walking in nature, spending time in nature, doing pottery, doing some exercise, and so on. I'm going to hand back to Chris now to tell you a bit more about the structure.
So this was a bereavement support retreat. We did not present it as grief therapy. And so there was the psychedelic element, but that was grafted onto or grounded upon a program of bereavement support that I was familiar with because it's the social workers at my institution use it for an 8-week parent program, but it was originally developed by social workers at Children's Hospital Boston, and it's grounded in the work of 2 kind of national movers and shakers in the bereavement support world, Doctors Alan Wolfold and Joanna Cacciatore. It again, rather than being couched as therapy or even group therapy, it's about support and connection. Hope Group stands for Healing Opportunities Parent Exchanges, and the parent exchanges are key. It starts with sharing stories of the lost children, not necessarily the stories of the death, but of the kids themselves. And the method of the group is really about holding the space for the parents to connect. So our Good Hope group we'll tell you more about in the coming slides about how we structured it, or what it was actually like to put a psychedelic aspect on top of this group. I think maybe the most important thing I can tell you about out of this slide is that we treated the protocol from the standard research studies of integration followed by the experience, preparation followed by the experience followed by integration as a sort of best practice. And then the other thing I'll mention off of the slide, which was a surprise for us, is largely palliative providers. That the parents who came to us were not bereaved by death of a child after long illness. They were bereaved by suicide, overdose, accident, and murder, which surprised us at first until we stepped back, took off our palliative hats, and thought about, well, how do children actually die? Most commonly in the U.S. And Canada, and then that made a little more sense to us. And again, so our paradigm for the retreat, this is again group and individual preparation. Some of that was online before we went down. There's group preparation at the retreat, which is kind of wedded and braided with the Hope Group model. Medicine Circle and Journey, Dingle will talk a little bit more about in a second. But those are the 2 experiences: group integration at the retreat, and then group and individual online work after we got home.
Okay, so I'm just going to speak a bit more in detail about each of those. So as Chris has said, we would have had online preparation. That would have been one-on-one with some of the facilitators or guides in our group. And then we had, very importantly, a group Zoom room so everybody could meet each other before they came. And a couple of parents said it was only when they came into the Zoom room that they were like, okay, we're really coming. There's not this load of crazy wackos taking us to Jamaica, and that we're actually quite normal people. So that was really important. We got in the feedback. And then, very importantly, the group preparation. So On the morning of the first day, we brought everybody into a beautiful yoga room space, which you'll see a picture of in a minute. Thank you. Standing on tiptoes here. And we sat around it. We treat it as a kind of, as a sacred space. And so we sit around on the floor on comfortable chairs, and we have an altar space in the middle of the room. And we had invited the parents to bring an object that meant something to them, that reminded them of their child, whether it was a photograph or some particular solid object. So that was a very important part, and everybody gets to hear everybody else's story. And as you can imagine, it can be very emotional. So then that evening is followed by what we call our medicine circle, which is where everybody sits in circle. It's a silent circle, and everybody, including the staff, take a microdose of about 250 milligrams. This is dried natural mushroom, as opposed to, I imagine, the synthetic mushrooms that are being used in synthetic psilocybin and other studies, so that's why the dose looks different. It's one of those spaces where you sit in silence, but if somebody wants to offer a song, a prayer, a reading, another memory of their child, then that's all possible. You do that, and then you go back to your seat and remain in silence. Sometimes silence lasts for many minutes. And then we have a day off after that, and then the following day is what we call the full dose journey, where people are lying down on foam mattresses. We recommend eye covering or keeping your eyes closed. We started off, most people, with 3 grams of dried mushroom, and a booster is generally offered between an hour and a half to 2 hours into the ceremony. I will say that at the beginning of the journey, we do open ceremonial sacred space, and we ask people to remain in the room. Sometimes people want to go out and lie down on the grass, but they're accompanied, and the agreement is that you will stay within the group until the ceremony is closed at the end. So these are some of the pictures of where we are. That's the lovely yoga space. You can see City and Circle and Good Hope. Funnily enough, the Hope group where we're working is actually called Good Hope. It was built in 1755, and it's a really fantastic setting. And obviously we have to incorporate a beach day into the week. Just let Chris talk to you about some parent outcomes.
So this wasn't a study. It was a bereavement support retreat, and even though we didn't do formal measures to track the parents, we just naturally stayed in touch with them and have had ongoing conversations. So we were aware of where everybody is. And in general, about 3/4 of the parents described a major life-changing shift in reconciling to their grief and getting unstuck in the process. When they came to us, most of them, they used that word "stuck," and that wasn't to imply that they expected or wanted even to get over things, but there was a sense that it could be different, and they wanted help with it. And both times, about 3/4 of them got exactly that. About 1/4 didn't really describe any change in their grief process, but half of those described a major shift in something else. They reconciled to some psycho-emotional material that's separate from their grief, but it was they still described it as healing, and it facilitated a shift in a different area of their life. All of them reported an enduring connection to members of the group as a major resource in coping going forward, and all of them happily so far would recommend the group to other parents in similar situations.
So this is our penultimate slide, and then we want to show you a 2.5-minute video, please, of testimony from a parent. So just to say that, since this happened, myself and my colleague Patrice Dwyer have become trained as psychedelic facilitators or guides. We have reorganized our organization to be more diverse and equitable. I run retreats now myself, particularly aimed for Jamaicans, which is different because most people are coming from overseas still. And I run an NGO called JACRI, Jamaica Cancer Care and Research Institute, and we are just literally this week launching a 1-week retreat as an experiential place for you to come, everybody, because many people are interested or training in psychedelic medicine but can't have a legal experience in the US or Canada. So we see that we'll be able to provide that sort of space for people to come and actually have a safe and legal experience in Jamaica and also go to the beach. And Good Hope has shifted from being a kind of regular tourist villa enterprise to something that now is specifically aimed at delivering psychedelic retreats. So that's been great for them too. And now we just need, so we'd want to show this video. This is very kindly put together by Nicole, Jackson's mom, and I'm probably going to need IT to get the video going, please.
Hi, I'm Nicole. And I lost this sweet boy in June of 2019, a week after he'd come home from graduating college and 2 weeks after his 22nd birthday. Slightly 2 years later, just less than that, I learned about the grief retreats in Jamaica and decided to, with some amount of trepidation, to attend and participate. It was done with such thoughtfulness, compassion, kindness, professionalism, and well thought out support for the gravity, the depth, and breadth of the grief that the parents felt. It was amazing. We set intentions for why we were there before we did the ceremony, and with clear understanding that you don't know what you're going to get or what may happen. I had two intentions. One was to communicate with Jackson in a way I hadn't yet experienced since he'd been gone, to have some connection with him, and to sort of finish unfinished business, that the things I never got to say or talk about from his childhood that I thought we'd always have an opportunity to address. I left there having had an experience where both of those intentions were met, and even more importantly has been the months after and since then, where the integration process has opened me up and made me understand the true impact of the ceremony and that the work that was done there. I have greater capacity to carry my grief forward. I have a new understanding of how Jackson and I are relating and how he is with me. I feel differently about the unfinished business, and I would absolutely recommend this to any other parent if they feel drawn to it, to do this kind of work. It has changed things for me in a way that I can't even fully describe in words, and I am so very grateful. I am absolutely happy to talk about my experience more or to answer questions if there's some interest in that, and you can get in contact with Chris or Dingle. They know how to reach me. Thank you.
So just some thank yous to the parents and the kids, who many of us felt were very present in the room during the ceremony, and to the other facilitators who were with us. Thank you very much.
Thank you so much. Dr. Farzin, thank you for your next, and I invite you to look at this screen so that you can be in front of the mics.
Yes, no problem. Thank you for having me. My name is Houman Farzin. I'm involved in a lot of projects. Most relevant, I have an outpatient palliative care practice at the Jewish General, faculty lecturer at McGill. I'm involved in the phase 3 trial of MDMA-assisted psychotherapy for PTSD sponsored by MAPS. And I work with Therasil. I'm a trainer, therapist, and a member of the training committee there. And most recently, Heroic Hearts, which is a veterans psychedelics focus group. So I'm hoping to touch up on a lot of these competencies. And basically, most people here are familiar with the suffering that takes place at the end of life. I want to talk about the potential positive role of psychedelics and give you an idea of all the exciting things that's been happening in Canada and some of the work that I've been doing here in Montreal. A quick ode to my mother, who inspired me to become a doctor. And so, as we know, palliative care is an approach, and we're here to talk about the psycho-spiritual elements, which we're not the best at treating, and we're hoping to change that with this work. As we know, palliative care was coined at McGill, so big shout out to Balfour Mount. And it's funny that patient's mom just mentioned unfinished business, but Balfour was inspired by Elizabeth Kubler-Ross, and there's the notion of the unfinished business and the fact that euthanasia could take away from that opportunity to address that unfinished business. And the reality is that as we approach end of life, we're more like a newborn, and that comes with a lot of suffering for most people. And the reality is that our spiritual needs are unmet, and sorry for powering through, there's a lot to cover. And as it was mentioned earlier, a desire for hastened death is the result of this suffering. And Canada, we have medical assistance in dying federally, and it started out more conservatively on the basis of freedom of choice and human rights, and it's becoming more and more easy to access it with a lot of the restrictions being removed. And starting next year, mental illness will also qualify for medical assistance in dying. So what's important is that meaning can be found until the very end, and we cherish this opportunity as palliative care providers to inspire change. And with psychedelic therapy, what we're doing is essentially creating an experience to change the attitude. So credit to Viktor Frankl. And psychedelic means mind manifesting. It was coined by Humphrey Osmond, who was living in Canada and writing a letter to Aldous Huxley, and he published it the next year. And what's important here is to know that psychedelic assisted therapy is not just like a one-time thing. It's a process, and the psychedelic experience is part of the process. It takes preparation, and most importantly, in my opinion, the integration that follows, and that can take a very long time, and it may require repeated sessions when there is the time and opportunity. So the first wave of research, so research into the use of psychedelics for this indication is actually very old. The first studies on psychedelics involved cancer patients and alcoholism. And even though some say close to 70% of studies conducted back then wouldn't pass an ethical review board today, they were important. And most likely when someone looks back 50 years from now at what we're doing now, they're going to have a lot of questions. And these are the seminal papers that started the next wave, some mentioned earlier, and the key ones are the 2 randomized controlled trials at Johns Hopkins and NYU, which demonstrate the safety, efficacy, and the fact that these results last a long time, and essentially the mystical experiences, as mentioned earlier, are correlated with positive outcomes. And so in Canada, 1 year after the United States, psilocybin was banned, and this continued until 2020, August, where after a 100-day campaign by Therasil, 4 patients were given permission by the health minister at the time, and that was followed by permission for healthcare professionals taking the Therasil training program to use legally psilocybin. And that continued in January of this year. The Special Access Program, which is a program that's existed, which is meant for doctors to be able to get medications that aren't currently approved in Canada. So they added psilocybin and MDMA to these medications that were once used for things like HIV medications. So we can now access that legally outside of a research study. And this is a picture of Bruce Tobin, who's the founder of Therasil, and that's Thomas Hartle, the first patient in Canada who took psilocybin legally. And he's a great speaker. He always presents at our trainings, and he's basically been repeating sessions every 6 months or so to treat his existential distress very successfully. And I want to talk about the first Section 56 exemption that was granted in Quebec. So the first access to psilocybin was similar to the first access to cannabis in Canada, and it was in the form of a Section 56 exemption where Health Canada allows a patient to obtain access to psilocybin that is either grown or bought in the black market, and then use it in a medical setting. And so my patient Nancy here is the first person in Quebec who got that late 2020. And it was a bit of an unfortunate story because her oncologist wasn't willing to allow her to have the psilocybin treatment because of the chemo. And this continued for a while. And unfortunately, by the time she was essentially deemed untreatable, we wanted to do her session, but this is a few days before we were going to treat her, and she unfortunately passed away. So she wasn't able to have that unfinished business dealt with. But we can see here, this is her home. This is the Quebec healthcare system, and despite all the challenges, we have some good services. So this is home care, palliative care. She has a hospital bed, and she was able to spend the last days of her life with her family in a very beautiful setting. But the work continued, and we got 2 more Section 56 exemptions, and so I'm going to talk about the treatments that we've done in the past few months. And so the first patient is a patient in her 60s, single, no children, lives alone, and lifelong struggles with depression and anxiety. And this is a pattern that I'm seeing over and over, is that people have had the depression, the anxiety over the years, but once they have a cancer diagnosis, everything gets worse, and with a recurrence, it keeps increasing, and once your life expectancy is really low, it just becomes out of hand a lot of times. So she has metastatic breast cancer with a prognosis of 1 to 2 years. She had psychedelic experiences in her youth, and her mother had schizophrenia, but we decided to treat her, and this is a photo from her living room, her actual living room, and we were doing it in a kind of traditional way in terms of the studies with the headphones and eye shades and the camera, me and a co-therapist. And this is what came out of her experience. This is integration of that experience in the form of art. And what we see is this black cloud of darkness that she's dealing with on a daily basis. And this experience gave her the opportunity to tap in. So this is her heart tapping into this beautiful world of colors that exists but is normally not accessible. And so we're working on her integration still, and we're planning for her second treatment next month. The second patient, also single, no children. A reminder that these are Section 56 exemptions, so they were actually 5 grams of dried cubensis mushroom. And so similar profile in terms of lifelong depression, anxiety, and it took a while to wean him off his medications, and he was struggling a lot. He's a patient with metastatic prostate cancer that's in remission, so his prognosis as of now is pretty good. And he's also someone who's had psychedelic experiences. And this is the altar that he set. We see his intention here, so intention setting is a big part of the psychedelic treatment. And then we also have other ceremonial items, and that's his grandmother who comforts him. I want to make sure we have the audio on because there will be 2 videos playing. And so this is an hour and a half into his session where he's struggling to enter that psychedelic state, and so he gets up and we have a conversation. And I'm going to show a quick clip of the exchange, and we're using an approach called internal family systems to help him kind of break through.
Shit. Fuck it. Fuck it. I hate being this person. I hate it. I fucking hate it, man. Fucking hate it.
I think these parts served a function at some point when you were born.
Yeah.
And we have to respect the parts and ask them to maybe take a step back because we're made of different parts. That's not you, it's just one part.
You're much wiser than I ever understood.
So
Really?
what followed here was a catharsis of 4.5 hours of crying, more than he had ever cried, and the result is visible.
Every day I look at the world from my window.
So it's the magic of psychedelic therapy. Credit to Dick Schwartz and IFS. And, it's about that acceptance and surrender and the humility and the euphoria that follows. So the third patient we treated, he was the first patient with the special access program, meaning that we actually got psilocybin from a licensed producer. And this gentleman essentially was spending the last months of his life in pain in his cottage up north. And he had no prior psychedelic experience, and he was actually planning for MAID. And this is the vial of psilocybin shipped to the Jewish General Hospital, which is pretty historic. 25 milligram dose. That's the cottage where we actually treated him. And this is the setting. He did not want the traditional setting. And so he was sitting here and, we were talking, and that's his cat looking at the situation. I just want to express my gratitude to him. He actually went ahead with MAID, and so he's no longer with us, but he had a profound mystical experience and was very thankful. So that one got some press. And so what we've learned is the importance of patient-centered care, and that a mystical experience doesn't eliminate all the suffering, but that doesn't make it insignificant. This patient was actually entering that same mystical state as his body was shutting down. And his decision for MAID wasn't altered, but that's not a bad thing. But we've learned to set realistic expectations and emphasize integration, the community building and creating options for group therapy, education, and of course doing this with humility. And I'm personally interested in music and intersection with technology and nature, so that's really big for me. But there's a lot of work being done to better define this trauma, study other substances, and promote inclusion, reciprocity, and equity. I didn't talk about the indigenous culture as much. It's been addressed a lot, but that's a huge passion of mine. I'm very respectful of them to be here now. And, it's important to address the underground and be mindful of the diagnostically excluded. There are a lot of people excluded this stage, and I'm really happy for McGill and a group of us that are getting together and under the leadership of Justin and others. So there's a lot of people to thank, and Justin, he's pretty much a co-author. So I really want to thank him for his support, and of course John Zigbee. We were able to do this work in the public system and bill through the Palliative Care Department of the Jewish General, which is a pretty historic feat, and of course Bernard Lapointe, Harvey Chang, Kyle Greenway, Sonny Karam, who's here. And this is our first cohort of trainees in the middle of the pandemic, and it was through this cohort that we were able to plan this training course and expand it. So thanks for your time.
Thank you very much, Dr. Farzin. Amazing work. And last, we're welcoming Dr. Reverend Jessica Rochester. Thank you.
Okay, before you go, you're going to show me what I need to do with this.
So,
Green button?
Can we have the slide deck? I think it's going to be that one. They're putting it there. Yes, next is here.
Oh.
It'll soon come.
Oh,
It will
okay,
soon
it's
come, yeah.
loading.
They're uploading it. Here.
Great.
Yeah, I think you're good. Does it work? Yes.
So I've been hearing this wonderful little ting, ting, ting. I wasn't sure if it was my hearing aids, the speakers, the whatever was going on, but I've translated that into kind of a magical, wonderful connection that we have in all these presentations. So I want to thank the speakers who came before me and those of you who are here this afternoon. I'm Reverend Dr. Jessica Rochester, and what I want to present today, I've been asked if I can weave a little bit of my own story in, and so I'll do my best to do that. And so that means we're going to click through really quickly some of these slides so I can do that. Sure. Is that better? Can everyone hear me? So just a word about who I am. I'm first of all, in order of importance, I'm a grandmother, I'm a mother, I'm a sister, I'm a daughter, I'm a friend, I'm many things. I'm an ordained interfaith minister with a doctorate in divinity. I'm the madrina of a Santo Daime church for 26 years. That's ayahuasca, For those of you who don't know, I brought the religion back from Brazil and founded the first church here. And so I just want to say to Ali, it took you 2 years. It took me 17 years of working with Health Canada to gain the first Section 56 exemption in Canada for an entheogen. A life mission. So be patient, gentlemen, be patient. May take longer. I want to give a shout out to our organizing committee, Dr. Monica Williams, who's with us today, our contributors, wonderful group of people, all who helped and supported. And I also trained with Dr. Stanislav Grof, so I'm a transpersonal counselor. I'm trained in the work of Dr. Roberto Saggioli, the Italian psychiatrist. So I have a very long history of working in what we're going to look at, non-ordinary states of consciousness. For me, it's 50 years of working in non-ordinary states. So we gathered together. I had a vision from the plants, the sacred plants that we work with. I was told in 2019, January, you're going to do 3 things. You're going to do a conference, and then there's a little project, and then you're going to publish books. Okay. So we put together the first conference on ayahuasca in Canada. If you're interested, all of the videos that I'm going to be connecting you to today are all connected to my website or on my website. So I'm going to do a couple of definitions. I'll let you read them. Some of you are probably very familiar with this. So entheogens, sacred plants, used for millennia. In Canada, 2 types of use. The Native American Church, that's peyote, and then there's us, the Santo Daime, and the União de Vegetal, they use the same sacrament. Millennia of use for these. Alternative use, you're probably very familiar with that, so I'm going to click through. There's obviously a lot of concerns. That's one of the reasons we kicked off this project. Psychedelics in Canada, so you're probably familiar with this too. And our concerns touch many areas. So non-ordinary states of consciousness, for those of you who are not familiar with what those are, it's difficult to define them because to do that we'd have to have a definition of an ordinary state of consciousness. And if we can just agree that there is no definition for that, then we're all on the same page. That consciousness is a continuum. And if you're interested in the topic, there's videos on my website. So we don't have one in Western civilization. We don't have one in our culture. And so a lot of the interest in psychedelics and entheogens is coming from a deep longing within us to understand beyond what we have in our culture. What has been lost through the indigenous, the colonization and the indigenous people here in what we know as Canada. And we understand that until very early, scientific inquiry was discouraged and only recently has been coming back. And a lot of what we would call spiritual experience or spontaneous non-ordinary states are pathologized. So our little project, that was item number 2 on our sacraments list of me to do. I gathered a couple of friends. I drafted up a kind of a little mission statement on what I thought we should be looking at. And some dear friends agreed, and then a bunch of other people jumped in, and the next thing you knew, we had a project that got published, and these are the 4 things that we focused on. So education, credentialing, ethics specific to the non-ordinary states. Yes, folks, it's a little different. There's just an extra piece that needs to be added. And the formation of a National Advisory Council, a multidisciplinary look at how to get all the people who are stakeholders sitting down together. So it's now 22 years I'm working with the Office of Controlled Substances, so I've gone through 9 different directors in the office, and so I knew where to start, when to speak to them about the project. And so we met with them. We have the support. It's tricky because it will involve provincial as well as federal understanding. So we are now in a political outreach. We are also very interested in having and connecting with ritual leaders, researchers, clinicians, clergy, educators. Our recommendations: maximizing spiritual and therapeutic benefits while reducing potential harm. So really understanding how to allow this wave of use for all the different ways that it can be used, that entheogens and psychedelics can take their place in a way that is honoring the heritage traditions as well as honoring the current research and finding a way forward that involves the voices of everyone. Spiritual care and treatment essential. And so here's a chart of the National Advisory Council. As you can see, if you start at the 12 o'clock position, access, diversity, and inclusion, I'm so glad to hear my esteemed colleagues here on the podium speak to this and say how essential it is. You know, I love that reference. I'm sorry, I forgot who said it about, you know, white women doing yoga, middle-aged. And this is a reality. We don't want to leave them out. They need to be very welcomed into all of the programs for what their needs are, but we definitely need to ensure accessibility for all those in need. So you have Native American Church Boughey, which has a regulatory amendment here in Canada and a long history of their own apprenticeships and rituals and training. You have us, the Santo Daime, União de Vegetal. If anybody can connect me to looking for the traditional indigenous people who are using mushrooms, we'd love to be able to connect with them here in Canada. So if you have a contact, connect with me, please. Spiritual care and clergy. Essential. We have the support of the CASC, the Canadian Association of Spiritual Care Providers. The association has written a letter of intent totally supporting the National Advisory Council because the need to integrate the variety of professionals who are working together. So and then you have a seat for each of the researchers and clinicians. We believe that each substance has its own specific, let's call it nature, okay? It may have a slightly different reaction one to another and therefore needs to be considered. And usually people who are working with ibogaine, for example, or who are working with psilocybin, they're finding things out that need to be discussed and shared together. Then you have a seat for the pharmaceutical industry and business because they need to be there. They are the people who are manufacturing the psychedelics, so they need to have their voice heard, and it's also a way of them getting feedback from those of us who have concerns about that business, harm reduction, and then of course education and credentialing. We imagine that credentialing would require a committee because it's important to include grandfathering. Does everybody know, you know what I mean, right, by grandfathering? Okay, advantages. This would give not just the government an opportunity to hear all the voices of the stakeholders, but everybody to share about risks, benefits, and it's an advisory council, not an advocacy council, not profit. Provides a forum to facilitate connections, collaborations for research, education, and wisdom sharing. Right now, a lot of us have been kind of wandering around a little bit. Do you know somebody? Do you know somebody who's doing this, who's doing that? Because I'm such a long time in kind of this field, I've ended up knowing people that hopefully will be able to know more people and gather people together. So we support norms and standards. We support the development of education. We know that there's currently at the University of Ottawa, at Vancouver Island University, there's programs being developed that are receiving the permission from their governors to be able to have these programs on psychedelic studies. How am I doing time-wise? Oops, sorry, I wanted to go back. How do I go back? The red one? Yes, good. Appointment structure, what we propose is that each seat would supply the OCS with a CV of a couple of people, and then the Health Canada can make the decision on that. That's the most neutral way that we could come up with. And for entheogen, traditional and ritual religious use, the communities themselves would decide on their representative. A required distinction between nonprofit and profit members with full disclosure of ownership and relationship and sponsorship structures. So, have I run out of time? So just a little note on me accomplishing the third thing that the Sacred Plants told me to do, which was publish. And Most of the material in this book is written, the foreword is by Paul Groff, wonderful and dear friend, and I wrote the book more of a channeling than a writing. My editor encouraged me to include quite a lot of my own story, my own spiritual journey and understandings and awakenings that I've had. In it, I include all of the cartography, the transpersonal maps and the cartography. So the books were really written, channeled and written, to be able to help people working in the field of non-ordinary states. It touches everything from ethics to, as I said, the cartography. And if you're interested at all, as I said on my website, there's more information about, you can connect with our paper. And those of you who are interested in entheogens and psychedelics, the proposals, I wish you all the best for the rest of the conference. I think it's nearly over. And can I give this back to you now? I'm looking forward to any of you have questions. Did I squeeze it in?
You did amazing. Yeah, you all did really great. I want to thank you. It's amazing to hear about all your great work. So please a round of applause for everybody. So it is 3:30 and the closing session is at 4. So you're welcome to stay now because we are going to hear from Dr. Williams, who is going to introduce our discussion and provide insights about what we heard now. I would invite you, if you have questions, to put them in the chat, because then we can look what you guys are asking about and maybe combine some of them for intervenants and moderate those questions. So thank you very much. If you can do that, you can use the app to enter your questions. Dr. Williams, thank you.
Thank you all. What an excellent way to showcase the many approaches we might take to psychedelics to advance end-of-life care and bereavement and to reduce suffering. We know, for example, that these research protocols, the studies that we're doing and the papers that we're publishing are only appropriate for a limited or narrow set of patients. My research is focused on disparities and how we can make innovations like psychedelics more inclusive and more appropriate for people who might otherwise not have access. It's certainly encouraging and even heartwarming to see the many different modalities that are being studied to help broaden the reach to larger segments of our society and our world, and to help ensure safety as these medicines move into the mainstream. Some important questions I want to put to you include, how do we move these research approaches from the ivory tower to the community? What do we need to understand as we do this work across national borders, cultures, and societies? I love the work of Dr. Spence in Jamaica, providing care for bereaved parents in the beautiful natural setting for Americans, Canadians, and importantly, Jamaicans. Psychedelic work seems to always travel hand in hand with spiritual or mystical experiences. How do we conduct our biomedical research in a way that we consider spiritual dimensions of a person's health and well-being, especially given that spiritual issues may become more salient at end of life? I thought Dr. Zarrabi's discussion about the roles of chaplains in palliative care was so critical. We're actually developing psychedelic training programs at the University of Ottawa, and we're partnering with St. Paul's University's School of Theology and its Counseling and Spirituality program to deliver this training for clergy and spiritual care practitioners, who I think are going to really need these tools. And when we consider the use of entheogens in ritual practice, how do we separate the chemical and psychosocial effects from the spiritual aspects? Or do we? What key things do palliative care providers need to know about psychedelics as more patients become aware of these options and start asking for them? How do we ensure the work is safe and acceptable to the variety of people who will need it? Dr. Zarrabi mentioned that despite the diversity of the Atlanta community, right in Atlanta, all the referrals for a psychedelic end-of-life study have been middle-class white people. And I just want to mention that culturally informed study design is my area, so like we can talk later. And as Dr. Farzin explained, can psychedelics help people find hope and meaning even at the end of life when so many patients may think there's no meaning left? And in terms of our safety and ethics, there's still so much work to be done in this area. Dr. Rochester's work, which I've had the privilege to be involved in, makes us think about how we can set up the structures and systems needed to ensure safety and accountability for these practices, where we maximize benefits and minimize harm. When we talk about the psychedelic renaissance, I think many of us doing this work are too quick to romanticize the era back in the 50s, 60s, and 70s called the first wave, where there was a lot of research going on legally, and it was like a free-for-all. Many people did benefit, but many people were harmed. And to all researchers, how are you using your resources and your platform to open up access to psychedelic therapies safely and to a wider and more diverse population facing end-of-life challenge, especially as psychedelics are becoming more prominent in the public eye? We have a lot of challenges ahead, but I am looking forward to it. So thank you. All right, just not to fall off the podium.
I'm really humbled by all the work that's being done and all the work that is to be done as well. I'll ask a first question that comes from the chat. Ruth Thompson is asking, so this is a question maybe more for Chris and Dingle. How are people referred to the grief retreat? What guidelines are there regarding the length of time post-children's death, etc.? So how do you select your participants? You have mics here if you want to answer.
The referrals came largely from therapists. Many or most of the parents actually had been in some kind of grief therapy, and their therapists heard about this opportunity and referred them. Or sometimes other parents who weren't the ones that came to the retreat but heard about it and passed the information on. Yvonne, sorry, the second part of that question?
The question was about whether you have a duration, before, of grief, before patients can, participants can enroll.
Yeah, the one thing that was on our mind was the notion of exclusion criteria, and that we wanted to put the whole enterprise fully in service of the parents and not have exclusion criteria that were for our benefit and not for theirs. Having said that, we meant it when we said safety first. We had a long process to clear the parents in terms of psychological and medical safety. But around that idea of, well, how long is long enough? Or, do they have to have complicated grief or some kind of diagnosis in order to be able to come? And in many ways, we left it up to them. And the main criteria, which I think came, I think it was Neil Houman, a psychiatrist on our team, who articulated this idea that, well, if they're in the really acute chaotic stage of their grief, then maybe that's not the right time to come and destabilize your psyche with a psychedelic. But that wasn't there wasn't a time limit on that, because some parents felt that for a few weeks and then it subsided. Some parents were in that for 6 months or a year. The other kind of along in tandem with that, the other question that we came up to hold together with the parents and the whole team is there an intention there? because it meant for the parents who were still in the chaos, it was hard to find an intention, and for the parents who were further out, whether in a way that wasn't just about time, their intention was there. They knew what they wanted, and they could work with it and develop it. So. Sorry, and we had a website, which some parents self-referred to us to that.
Just to say that's Jamaica Grief Retreats. So if you know anybody or want to look at it yourself, it's called jamaicagriefretreats.org, and that's up now.
Thank you very much. Maybe I'll ask a question to those of you, Dr. Reverend Rochester and Dr. Farzin, who have conducted either ceremonies or psychedelic more in the community, psychedelic work. What gets you to choose to repeat a dosing, and how do you, that's a question that is not even yet very tackled by most of the research at the end of life. We use one psilocybin session and we measure pre-post effect, but it seems, Dr. Farzin, you've experienced that it might be useful for some patients to repeat the dose. You've mentioned every 6 months. I'm sure in a more sacramental setting, there is also the opportunity to repeat the actual psychedelic experience. Can you tell us maybe a little bit about the value of having repeated experience? And do you see maybe potentially any harm or pitfalls to that?
Can you hear me? Yes?
Yes.
So the spiritual use, the ritual use is different to the therapeutic use. And first of all, the Santo Daime is non-soliciting. We do not proselytize. We do not solicit. As a matter of fact, it's kind of a lot like the ashrams, the real Indian ashrams, where you have to go and sit by the gate if you want to meet the teacher, and you sit there for 3 days to prove that you're really serious about wanting to meet the teacher. You have to apply and get visitors' information. You have to fill out forms. You have to be screened. There's interviews. And people have to be very serious before they attend. It's not something that we take at all lightly. And that's just to come and visit and to participate in a ritual. For people to become members, you have to go through a similar process. We have an interim step called associate membership, where people who are really serious about following the path. And in the religious use or the spiritual use, there's a calendar. There's 2 works every month. Now, this is not imposed, but people who is called taking your start, people who take full membership in the practice understand that the commitment, it's kind of like dating and then engaged and then married. When you're just dating, there's one kind of a relationship, and then when you're married, it's quite a different relationship. And it's the same with any spiritual tradition around the world. If you're serious about it, you make a commitment to it. What's quite remarkable is there's also this understanding that why is it twice a month? Because that's what was established through 100 years of the Santo Daime, before that thousands of years of indigenous use. It's not every week, it's not once every 6 months, it's twice a month.
Thanks. Yes, in this context, because we're doing this as a clinical practice and not a study, we have the liberty to really be patient-centric. The way I approach it is that I make sure that we're doing it, first of all, for the right reasons if we're repeating. For example, 1 or 2 patients had their Section 56 applications expiring a year after they were issued, and they wanted to get a second session in just because. And to me, that's not a right reason. So what we do is we make sure that they fully integrated that first experience, that we've fully utilized that experience to create lifestyle changes. And once we feel that we're at a place that, that experience is going to be truly beneficial, and the first one has been fully digested, as Alan Watts puts it, then, if they still meet all the inclusion criteria, we can proceed to the second stage. But the reality is we don't have enough evidence to know. And so for now, we're doing case-by-case basis and definitely erring on the side of caution. And it's also important what substance we're talking about. So this is psilocybin. For example, with ketamine, we tend to do repeated sessions in a shorter period of time. So it's very case by case.
Thank you so much. 5 grams of dried mushrooms feels like higher than the 25 milligrams of psilocybin. You know, what led you to choose to use 5 grams for that specific patient?
I mean, the 5 grams is a traditional dose, and so I'm going based on a Therasil protocol. The reality is psilocybin is like cannabis, so you have different concentrations of psilocybin based on the strain. But the 5 grams of an average strain, when the extractions were initially done, actually, the story of when Albert Hofmann initially isolated psilocybin, they equated roughly 5 grams equals 25 to 35 milligrams of psilocybin. So it's in that range, but it seems like the 25 milligrams is like the sweet spot based on all the recent research. And our patient had a full mystical experience with the 25 milligrams without really any side effects.
Thank you. Yeah. I don't think I have more questions in the chat, so feel free if some of you want to have more questions.
Thank you. Hear me? Do I have a booming voice? I love my booming voice. I'm Gerard Huney. I am a very lucky person. I live an hour away, and I'm part of the McGill community somehow because I trained in family med and anesthesiology and palliative care. So I every day administer non-ordinary states of consciousness. I also have a very busy chronic pain practice, non-cancer chronic pain practice, which is 20% of my time, but 80% of my concern. And I think we're going to shake hands at some point because this is perhaps a take-home message. The language that's being used is exactly what our field is using as well. Getting unstuck, moving on, taking the opportunity to complete unfinished business, and to have people be coached in a sense, chemically or through accompaniment, through this grinding, chronic grief. So the people that I see use words like my injury, my accident, my impairment, my handicap, my pain, and I think they one day will also be susceptible to this molecule, and perhaps not at 25 milligrams, but at smaller doses. So with ketamine, we're disappointing a lot of people. With lidocaine, we're disappointing a lot of people. Thankfully, we have another therapeutic class now that we'll be able to propose to our population, thanks to your work. So I can't wait till you speak at our conferences so that perhaps we could take baby steps towards relieving another sector of the population. So thank you. I want to thank you.
Thank you very much for that comment. Does anyone want to add something about the... Yeah, I think I know of at least one study on fibromyalgia with psilocybin. I think it's at Johns Hopkins University, starting. Yeah. And yes, and highlight, you mentioned it, the overlap between trauma and chronic pain, is also a clinical reality. So definitely some place for that. Thank you. Yeah. Yes, welcome.
Hello, thank you. My name's Katrina Sink. I'm a hospice and palliative medicine physician in Maine. And my question is for those of us who practice in areas where we don't have access to this type of research and so forth. Maine's an interesting place. Cannabis is legal and people like drugs. So a lot of people do microdose psilocybin. And I'm wondering, just from a very practical standpoint, if a patient brings this up with me, what can I tell them about how to be safe with it? Or are there online resources I can point them to? So if they're going to do this on their own, I can provide them with accurate and helpful information.
Thank you for that question. Yeah. Who wants to take a stab at it?
I'll take a stab at it. There are plenty of people, I mentioned 2 years, right? So there's been a lot of hype about this tiny little study at our institution, and tons of our patients want access to it who don't qualify because of our stringent exclusion criteria. So there are underground practices. They're not that underground. They have websites, and they provide therapies either in South America or locally. And I know many of these shamanic practitioners, and what our psycho-oncologists are doing and our palliative folks are doing is we are tapering our patients off of certain serotonergic agents, and we are providing as best as we can aftercare. You can, oh, yeah, mask off? Okay. Yeah, I mean, it's not perfect. This is a harm reduction approach that we're doing. But if they're going to do it anyway, we want to be aware. And I ask my patients to tell me, and then I hook them up with our psychiatrist as well. It's not perfect. And I wonder if anyone else on this panel has a better harm reduction approach.
We have an advisory on our website, which actually is just changing servers, so it's down for a couple of days, but that's not my personal website is up, but our church's is down. And we have an advisory for external events, which is something I drafted up quite a few years ago when I realized that a lot of people were trying to come to us in situations where we actually couldn't serve them because we are contraindicated for certain medical conditions and certain medications. And so the advisory is very simple, and it advises people to ensure the legality, the safety, who is leading the ritual if they're going to participate, or the event or the retreat, who is running it, what are their credentials, how have they trained, who do they represent, exactly what will you be served, the effects that you can expect, and who does the preparation and who does the integration. And those are the questions that absolutely need to be asked. And so if any of you are interested, you'll find that, advisory on external events, or write to me and I'll send you a copy. But that's the advice that really needs to be given. Who's serving me? What are they serving me? How are they going to prepare me? How are they going to help me integrate? And what am I taking?
I'll just add a mention of an organization called the Fireside Project, which is a kind of peer support model. Though the folks who staff it, they're coming also from a harm reduction angle, but they're available. It's gearing out of, I think, just crisis support and more sort of general support. So it's a way for anybody, no matter where you live, you can essentially access somebody who can bring some of the skills of a guide or a facilitator to support you. And I think it's just firesideproject.org.
Yeah, and I don't have a mic, so I'm just going to stand up here and chime in also. So at my outpatient clinic in Connecticut, we will encourage people if they seem like good candidates for the ketamine-assisted therapy, which I know is not. Is not necessarily the right thing for everyone. We do actually now have a partnership with an MD in Ecuador who also is an indigenous practitioner, and we're able to send clients there as well, and he practices with ayahuasca and with psilocybin and San Pedro. And recently we've actually been able to get a number of scholarships so that we could send people of color to Ecuador, in a manner that they can afford. So that's one solution that we've found.
Thank you very much. We're going to take a last question maybe, and then head up to the last closing session with a short break. Thank you all for staying.
Hello, can you guys hear me? Yes. My name is Arshi. I'm R1 Family Medicine at McGill. Thank you so much for your talk. It's very exciting to see these substances finally get the respect that they deserve. I had two questions, one more from the clinical aspect of things and one more from a research aspect. For the clinical side of things, Dr. Farzin, I was curious, so from my understanding, 5 grams of dried mushrooms is, considered to be a pretty impressive dose. Some would call it even they would call it like an ego dissolution type of dose, or even a quote unquote heroic dose. For your patients who I don't know if you've conducted these ceremonies with patients who are psychedelic naive, but how do you prepare them for these sessions? Because, you know, these substances are very much in a lane of their own, and there's not really anything that's even close to what these experiences are like. So can you kind of take us through a little bit of how you coach these patients through these ceremonies?
Can you do that in 30 heroic seconds?
Yeah. I mean, it's a case-by-case scenario, and the reality is, for patients that are psychedelic naive, they typically require higher doses to break through the barriers and the defenses that have built up over a lifetime of suffering. And so, you know, someone who's had experience with altered states of consciousness will probably get a similar experience with a lower dose. But the reality is that people that have a lot to deal with, they actually need that punch to break through. And so that's part of the process. But using things like holotropic breath work and other natural ways to achieve non-ordinary states is definitely another option.
Very interesting, thank you. And just one last quick thing. Do you guys foresee challenges in designing you know, robust, like double-blind, placebo-controlled trials in the future with, you know, like controlled substances that are supposed to be something that, I guess, designing studies where it would make it difficult not for the participants to be unblinded, if that makes sense. Let's say if you're comparing something like psilocybin to like a comparator, like, you know, I've seen studies use methylphenidate, which is like very, very different. So how would you ensure that the study, from the perspective of the participants and the researchers themselves, are being adequately blinded to prevent bias throughout the study, if that makes sense?
May I refer you to Rick Dublin's 1,000 pages thesis, maybe, on the question? I don't know if there is a good answer, but yes, it is challenging.
Yeah.
One thing I'll add is that now we're developing essentially similar structures to psychedelics that aren't psychoactive.
Okay.
Those are starting to be studied, and so that would be one way to compare similar compounds, one with a psychedelic effect and one without.
Right.
Yeah, and the blinding will remain challenging. Or, yeah, but people use active placebos, you know, that can have, as shams, of an effect that can be more easily confounded with the psychedelic effect, but the reality is that more than 95% of people guessed right what they had. Yeah.
Right. Cool. Thank you so much.
Thank you very much. Thank you all.